For many of us, they are the most familiar faces we see in healthcare, our family doctors. And while they may not be in an ICU or an emergency room, they are critically important during this crisis for assessments and for ongoing health needs. How are they doing in these trying times? Let's find out. From three family docs, we welcome in Marathon, Ontario, on the North Shore of Lake Superior, Dr. Sarah Newberry, who practices at Marathon Family Health. She's Chief of Staff at the Wilson Memorial General Hospital. In Peterborough, in Central Ontario, Dr. Thomas Richard from the Peterborough Family Health Team. He's president of the Association of Family Health Teams of Ontario. And in Willowdale, here in the provincial capital, Dr. Javid Alou, physician at Nymark Medical Centre, who's also on staff at CAMH, the Centre for Addiction and Mental Health. And we are happy to welcome you three GPs to our program tonight. I'd like to start, actually, and maybe Dr. Sarah, you could get us started. I think our viewers would be interested in just a better sense of what your practice is like. Why don't we start there?
Thanks so much, Steve. I'm really happy to begin to describe that a little bit and share with listeners that the experience for rural family physicians and rural generalists has been huge over the last several weeks. You had mentioned that many family physicians don't work in emerge departments, but the reality for rural family physicians is that we are both in our primary care office settings, where we have transitioned almost fully to virtual care. We are working in our emerge departments. We are providing inpatient care, managing our long-term care and chronic care settings. We have a small RAM clinic here, an addictions clinic that we also run, and we certainly continue to provide support to our Indigenous communities and home care locally as well. So our practice is very full and varied, and COVID-19 has asked much of us in all of those domains of care.
To be continued on that front in just a second. Dr. Thomas, tell us about your practice in Peterborough.
Thanks, Steve. So it's a family practice. Peterborough's a medium-sized town, so a lot of the physicians here have dual roles. They're palliative care. They may be doing low-risk obstetrics. Some of them work in emerge. Personally, I'm doing primarily office care, and I also teach. We have residents that we train. It's been a huge impact. As Sarah was alluding to, COVID's completely changed the way we practice. I would say probably 95% of what we're doing is virtual now to try and keep those higher risk patients away. There are still those situations that require patients. There's well baby checks, there's prenatal visits. There's a number of things that you just can't do virtually, and you still need to assess patients. Mm-hmm. Fortunately, we are part of a family health team, which is fabulous. So it's a lot more than just family physicians. We have nurse practitioners that are just doing a fabulous job. We have an NPLC in our town that's helping look after a nurse practitioner-led clinic. That's helping look after some of our disadvantaged and homeless people. So we've really reorganized how we provide care. And I think being in a family health team has really allowed that to happen a little bit easier. I mean, I think we had a sort of a step up in our organization, which allowed us, it was a little easier to maybe get things going than maybe in some other communities.
Gotcha. Dr. Javid, how about you?
Thanks. Actually, the area I work in is actually a very densely urban and suburban area. So our patients are from a large territory and actually have very fragmented access to care. So unlike smaller communities, we actually have a chance to integrate more. The patients and the providers working in suburban areas like Toronto and Ottawa and larger cities actually have a harder time getting connected care. And we see that in a high burden of illness and few accesses and established pathways of care for both chronic care and mental health care, which is a large part of my practice right now.
Now, are you practicing mostly virtual care right now as well?
So our group practice actually functions in both ways. We actually did a lot of urgent care, in-person care, and also for the mental health care I do, it actually lends itself much better to virtual care. So I personally have been doing a lot of virtual care. This is the setup where I work, but our practice is still running 5 days a week, seeing patients every day. That's still a reduction from our 7 days a week, long hours that we had because of the challenges we'll discuss later.
Okay. I wonder, Dr. Sarah, maybe you could pick up on this. From the sounds of your practice, you are all over the place. You're out and about. And I wonder if that is both a greater risk to you and your patients, the fact that you actually are in multiple settings.
I think that's a really important question, Steve, because certainly one of the things that we want to do is minimize exposure risk to our patients. One of the things that we've done locally is create a respiratory assessment center, which is attached to our clinic, but in fact completely separate from it, so that we're seeing patients who have symptoms of COVID but don't require the emergency department in that setting, reserving our clinic space for the patients that we should be seeing in person for the things that Tom mentioned. So well baby checks and prenatal visits, shoulder and knee injections, the kinds of things that maybe shouldn't wait for very long. And so we've separated those spaces completely. And to Tom's point as well, we also have the resources of a family health team, and we have asked our terrific nurse practitioner to be what we're considering cold zones, so the spaces that we don't want to put at risk from COVID. So we've asked him to function in our chronic care and our senior supportive housing to be the point of first contact for those patients. And he will not work in the respiratory assessment center or in the emerge department. We will support him virtually. So he might see a patient and bring an iPad, and we can join into the conversation with him as needed virtually for those highly vulnerable patients. But really, we are wanting to conserve our physician resources to function in more of the hot zone settings, the emerge department and the respiratory assessment clinic in particular.
Understood. You mentioned you've had some patients with COVID symptoms. Have you had anybody with the actual virus?
We have not had anyone who's been documented as COVID positive in our community. We have functioned with the assumption that it is likely here. We had several people who were away for spring break and many snowbirds who were wintering abroad and who came back to the community towards the end of spring break. And so we assumed that COVID-19 was here. People were terrific about self-isolating as they were asked. And we really worked hard to get out in front of that messaging with our community and really tried to support the community as much as we could as a health system with their self-isolation practices. So we have no documented COVID-19 in our community, although it is here certainly in the region.
Okay. Dr. Thomas, how about you? Any confirmed cases that you've had to deal with?
Yeah, Peterborough is actually running about half the provincial average. We have 60 confirmed cases in our area, and a number of patients in the hospital where we're still waiting for some results to come through. The turnaround time is greatly improved, but with the push on increased testing, particularly long-term care, it has caused a little bit more delay in the last little bit. We've all sort of rallied around our services and our supports to really try and make sure that we have enough PPE to look after those patients, even the ones that we don't think have COVID. I mean, the reality is PPE is getting very short in a lot of clinics. And,
do you have enough where you are right now?
Where I am, I have enough, but I have colleagues who don't have enough. And, you know, we're in the process of trying to share. The hospital, I have to say, has been fabulous. In Peterborough, we have one hospital, and they have been working with primary care, trying to ensure that we don't run out of PPE, but I mean, they have their own limitations. And the reality is they know if we have to shut down because we can't protect our staff, we can't protect ourselves, then that means there's going to be an increased demand on their services.
Sure.
And there's no one we want to go to the emerge if we don't have to send them there.
Of course. Dr. Javid, how about you? Any confirmed cases of COVID that you've dealt with?
So actually some challenging cases. So I've had patients who have very high symptoms, high risk exposure earlier on, and we got them tested, and the initial test was negative, but we recognize now that the test is up to a 30% false negative. And so I think the reality is we're recognizing patients in the community where the testing levels are very low actually have a much higher burden of COVID than we recognize right now with the numbers we're looking at. So we have patients we're already isolating, monitoring, and we actually were not even with earlier guidelines allowed to get some of these patients tested, even though there's a high risk of exposure at the time. So patients we're monitoring closely, remotely, on a regular basis to make sure they're safe. And I've talked to colleagues who've actually had a lot more burdens.
And what's your circumstances for personal protective equipment for you and your team?
So when we began this conversation 3 weeks ago, we actually had whatever was left over from the H1N1 pandemic. And since then, we've actually had an outpouring support from the public, beginning to get some of us started. And that helped us tide through till the present moment. So our clinic is actually running with a very short amount of PPE left that we're actually sharing we can with others, and we're having the same response. We heard from the ministry that they're going to hopefully allow primary care to have access soon, but still everybody's waiting and hearing, and the guidelines aren't clear. Will small practices all across Toronto and other parts of the province actually have access to PPE to care for patients for these chronic needs that haven't gone away?
Dr. Sarah, what's your situation with PPE?
So like Tom, we have a terrific collaboration with our local hospital, and we've been able to share PPE between our primary care setting and the hospital. We've had many people in the community step up to make washable surgical gowns that we're using in our assessment center, to make cloth masks that we're providing to patients so that we can conserve the surgical masks that we have. And as Javed mentioned, we've had just terrific donations from people, including from people in Richmond Hill, which was surprising and lovely. So at this point, we seem to be okay. That is not having any COVID-19 cases currently. So the demand for our PPE is low in the hospital setting currently, although we're certainly using it robustly in the assessment center and in our emerge department.
And just follow up, if you would, which group of your patients are you most worried about at this time?
Yeah, so there are certainly several groups, and all people living in rural, remote, isolated, and Indigenous communities have been identified as a high priority population by the Ministry of Health under the testing guidelines. We have been using the language of rigorous protection of our vulnerable population, and that is particularly our patients who live in chronic care in our hospital, our patients who live in senior supportive housing, which is a congregate seniors housing facility, and our independent seniors at home. So we have been working very hard to protect those populations. In addition, though, clearly our Indigenous population, we have 2 Indigenous communities that we serve through our local health hub, and they have just been terrific in their leadership and their support of protection of their citizens. But certainly the Indigenous population is a vulnerable population as well, and we have a focus on how we support and work with those communities as well.
Dr. Thomas, how about you? Who are you worried about the most?
Well, I'm really worried about the patients who aren't coming in. I think there's when COVID struck, we noticed a distinct drop in the number of patients coming in for things that you just wouldn't expect. There are medical conditions that we know aren't going to change, things like appendicitis and pancreatitis and injuries and stuff. And people, I think, were fearful and they weren't coming in. And a big part of the messaging in our community over the last little while was really trying to say is, we're available, we're here, don't be afraid. We've taken precautions as best we can to keep you safe, but you may be at more risk by ignoring some of these things and putting things off that need to be dealt with now.
Do you find that a tough sell with your patients, that they're just really afraid to come into a place where there will be a lot of other sick people in their presence?
So, well, I mean, keep in mind the sick people, as Sarah said, we have a COVID assessment center. So really those people that we are suspicious aren't being coming into the building. They're being directed to a separate facility. It was more difficult, I would say, a week or so, 2 weeks ago. I think people are kind of reaching the limit of what they're willing to tolerate. I've noticed just in the last week and a half, there's been much more uptake that people are coming in and expressing the need for some help. And I'm happy to see that. And I hope it continues. And I hope people develop some confidence that we have a system in place to take care of them.
Dr. Javed, have you had a situation yet where, for example, a patient probably ought to come in for a checkup on something, but is afraid to come in, doesn't want to come in? And if so, what do you do?
That's actually very important. Actually, the patient whose daughter actually made an appointment for her by video conference because she had a breast lump that she complained to her daughter about that she felt just recently. That was 2 weeks ago. So I had the videos with her, and there was some reason to worry less but certainly we actually said, hey, these are the way we can actually take care of you safely and assess you and the protocols we had in place. And she still was concerned. So we gave her some options and a range of follow-ups. That actually means more careful monitoring. We're seeing her again by video in a week's time and actually going to talk to her about coming in then. So there are people who are deferring care who shouldn't be deferring care because of the fears they have about COVID, despite the assurances we have. And that means a lot more work to make sure they actually get the care when they need it.
Wow. So this is somebody who well, I mean, God forbid, but who knows, who may be dealing with breast cancer, who's afraid to come in because of COVID-19?
That's right. I had somebody else, a younger person, who actually had bleeding that actually was considering and worrisome for having colon cancer, who actually did agree to come in, and actually we have arranged for testing in the last week alone. We've had patients who actually had decompensations in their sugar control to the level where I have to start insulin over video in the last 2 weeks and actually monitor them carefully and teach them how to use it using YouTube and other video conferencing technology. So it's a lot of acute care still happening, and the demand for services for me personally, for my family practice, has just become double nearly in the last 2 weeks, and it's been hard to keep up with.
Are you the kind of doctor who could say to a patient on a video screen under those circumstances, you got troubles, get your tushy, get your fanny in here right away and let's have a look at you. Come on, stop fooling around. You do that?
I'm pretty blunt, but definitely. But the reality is recognizing what actually motivates people and understanding for some people being very blunt and clear works. And for some people, they need to know that you're not heightening their fear because that makes them shut down and avoid even more. So we're doing a lot of careful social management, behavioral management, and it's even more challenging to do it obviously over video than it is in person, where we can reassure in so many more ways.
Dr. Sarah, let me ask you a bit of a controversial question here, which is we've talked to numbers of people on this program in the past about how many people from indigenous communities are extremely suspicious of what they refer to as colonial medicine. And, in their view, Western medicine doesn't necessarily take into account many of the indigenous traditions or ways which, in their view, would make their sick people healthier faster. Is that something you've had to negotiate your way around during this crisis?
So I would say no, it hasn't been, and I won't speak for Indigenous communities. What I can say is that the leadership and support that the Indigenous communities that we work with has been just tremendous and terrific, and they have moved very quickly to protect their citizens, to protect their vulnerable elders, to ensure that people in their communities who continue to require care have access to clinic services, either virtually or by bringing them into the community. And so that has not been part of my experience of providing care locally at all.
Okay, good to hear. Let me go around the table here, our virtual table here, by asking each of you how much you worry about your own health at a time like this, because obviously you can't help us if you get sick. So let's start there. Dr. Thomas, how much do you worry about your own health at the moment?
Yeah, I mean, it's a concern. I think it's part of what you sign up for when you agree to do this job too. And I think it's a certain amount of risk that you accept. But I mean, you of course you do the best you can to protect yourself. You're wearing your PPE, you're following your infection control protocols. You're doing what you can do to try and do your job as safely as possible. And, that's part of the value of the virtual assessments as well. Not only is it less risk to our patients, it's less risk to us. It allows us to keep going and keep doing the job. We realize if the medical workforce and all our support people, our nurses, our nurse practitioners, if everyone gets sick as well, then we're not going to be able to provide the care we need. So it's there. It's in the back of my mind. The biggest thing is the guilt. I mean, I certainly wouldn't want to bring this home to my family. I haven't taken as far as living in the garage. It's still too cold in my garage. So, but we're doing the best we can to try and reduce the risk.
Good. Dr. Sarah, how about you? I mean, we understand that risk is part of your business, and signing up for some risk comes with the territory. But I don't know that any of you signed up for a global pandemic the likes of this.
Yeah, I think that's true. But like Tom, I think there's not, we do have to recognize that we continue to have a duty of care to our communities. And as long as we have access to personal protective equipment and are using it and stewarding that personal protective equipment wisely, then I think that we can protect ourselves. And I think the language that I've used around this is that I feel very alert, but not anxious. And I try and hold myself in that space because I think being alert about the risk makes us be careful and cautious about how we protect ourselves. But anxiety and fear for me becomes quite paralyzing, and it's not helpful. So I feel very alert about this issue. I don't feel anxious about it. I feel mindful about the risk that I take, certainly for myself, but also because our health human resources, not only in Marathon, but broadly across the North, are very fragile. And so we have moved in the last couple of weeks to wearing cloth masks, even in our clinic setting when we're simply interacting with one another, because we can't always maintain social distancing. And if I become sick and am asymptomatic and pass COVID-19 along to a colleague, it will be very quick that our local healthcare system is incapacitated. We just don't have a robust human resource, and taking out one or two family physicians from our primary care setting also means that we've lost one or two from our inpatient and emerge department roster. And so we are very careful about how we are using PPE and how we are protecting ourselves, because protecting ourselves helps to protect all of our group, and that allows us to continue to provide safe services for the whole of our community. And that's really, I think, what is informing the way that we do this and move forward together.
Dr. Javin, in asking you the same question, I should also set up the fact that I think you started your career, or at least I was told you started your career when SARS hit 17 years ago. We all know that SARS killed 44 people here in the capital city, and most of them were in healthcare. So how does all of that inform how you are taking care of your own health right now?
So you're very right. So the practice actually I first joined when I finished my residency was a practice where actually one of the physicians got SARS from a patient that he was taking care of. And very quickly, several other physicians in that practice got SARS as well, with significant life-altering complications for them. So I recognized very early on the risk is very real, and the significance and implications are quite high, including morbidity and death. So the idea wasn't to deny that risk or to minimize that risk, but to recognize and accept it and begin to work around it. And I think that's what we're looking to do, which is why the concern about PPE, which is much more of a challenge in the smaller fragmented systems we have in urban areas than we do in large organized healthcare. So these practices don't have access to PPE or infection control protocols to the same degree, and are looking and learning on the job very, very quickly. So the risks for actually having errors in maintenance are much higher in these settings. These are practices that are not as well trained, are not as well supported in those protocols. And so the concern is, how do we actually minimize the risk, which is why we're shifting even probably at a higher rate to virtual care, because we know that's probably the only way we can do things safely in many settings, and really reserving the PPE for those contexts of use where patients need to be seen and where staff can be protected while they're giving that care as well.
Gotcha. Just to set up the last part of our discussion here, I want to read something that an Ottawa family doc named Barry Dworkin wrote. It was reprinted in the Toronto Sun just a few days ago. He wrote, "The issue is straightforward. Since mid-March, the pandemic public health guidelines have restricted patients' access to their doctor's office or medical center. Therefore, your doctor cannot use the usual billing codes for in-office appointments. The government's decision to not pay physicians for their services until mid-June or July, because they cannot program their computers to accept the 5 extra virtual medicine fee codes, risks the closure of your doctor's office, and for some, permanently. Doctors have the same expenses as other small businesses." Let's get an understanding of whether or not any of you are taking a financial hit right now, and whether it, risks the future viability of your practice. Dr. Thomas, what do you think?
So we have had a small hit. I don't work fee for service, so it's not a piecemeal sort of compensation. I'm paid under a model we call capitation, which means I'm a larger sum of money for a year. Because of that, my hit's going to be maybe 20 to 30%. And it's certainly enough that I would be able to keep the doors open. But there certainly are physicians who are going to be impacted by this tremendously.
Now,
And
does this
I
mean
feel
you've had
for
to
them.
lay people off if you're down 30%?
No, I'm paying for them anyway. I've changed the way they're working. So my receptionist may be working from home, and we have call forwarding and things like that to reduce her risk. There's maybe some comorbidities involved, so we're trying to reduce risk for our staff where we can, but I'm continuing to pay them their full salary.
Out of your pocket?
Yes.
Got it. Dr. Javid, how about you? Any financial hit because of all this?
So actually in the Toronto area and the surrounding area, a lot of the physicians, the majority in fact, are actually paid and supported with funding per service. And so there's significant impact in these areas. So in our practice, we've had to reduce the number of days and hours we serve already. And so there's been significant impact, especially since we're already purchasing PPE at really high prices out of pocket because we weren't getting any from the system.
Have you had to lay anybody off?
So we've reduced hours already. Hoping that we can increase capacity again over the next couple of weeks, recognizing the demand will come back big and strong and hard for care, and we need to have the ability to rev up quickly. So this loss of infrastructure in the meanwhile is actually very worrisome.
I don't want to put words in your mouth, but is this nuts that they can't figure this out to keep you guys in business? I mean, we kind of need you now.
So the biggest worry we have, and this is an informational gap and attentional gap we're seeing about COVID. So we saw this whole focus on acute care everywhere in the world, not recognizing the biggest dangers were actually outside of the hospital and that the support should happen there. So there is no reason why this couldn't be allowed to happen, and it's more of an administrative decision rather than a capacity decision.
Dr. Sarah, how about you? The financial hit?
No, not here, actually. So we are funded under a sessional funding agreement. Locally, we have funding for 6 physicians. We share that funding amongst 8. And there will not, to my knowledge, be any change to that compensation. There hasn't been a mechanism to pay for the many hours that physicians have invested to be able to do the work that's needed to be done as a sort of collaborative clinical leadership group to pivot around so many of the issues that we've had to deal with, but we will not anticipate a change in our funding. What I would say though, Steve, is that the question that you're raising really highlights that there is an inequity in the way in which family physicians are paid broadly across the province, and there are challenges to the way in which primary care is done broadly from an infrastructure standpoint. And I think as we begin to learn and understand how this has impacted some physician practices, and as a consequence of that impacted patients, we need to take these lessons and look forward and say, what is it that needs to change about primary care in the province of Ontario so that all care is better as we move forward, so that all physicians are more equitably paid and resourced, even from things like the PPE, because we want every family physician to remain as fully engaged in care delivery as they can. Family physicians matter. Primary care as a sector matters to the way that healthcare is delivered in this province. And if we can capture this lesson now and carry that forward, we will have gained from this opportunity.
Well, that lesson learned may be a good place to leave this conversation. I want to thank the 3 of you for coming on TVO tonight and sharing your experiences with us. Dr. Sarah Newberry in Marathon, Ontario, Dr. Thomas Richard in Peterborough, Ontario, Dr. Javid Alou, just 15 minutes up the street or so from where I am right now, in North York, Ontario. Great to have you all on TVO, and be safe out there, okay?
Great.
Thanks so much.
Thank you, Steve. Bye-bye.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.